Everolimus or Everolimus. MTOR kinase inhibitor, immunosuppressant, anti-neoplastic agent, used for the treatment of advanced hormone receptor positive, HER2 negative breast cancer in postmenopausal patients in combination with exemestane and after letrozole or anastrozole failure, and used for prophylaxis of organ rejection in adult kidney transplant recipients at low to moderate immunologic risk in combination with basaliximab induction and concurrent with corticosteroid and reduced doses of cyclosporine, and used for the prophylaxis of allograft rejection in liver transplantation in adults in combination with corticosteroids and reduced doses of tacrolimus. Everolimus shouldn't be administered earlier than 30 days post-transplant, and used for the treatment of locally advanced metastatic or unresectable progressive pancreatic neuroendocrine tumors, PNET or PNET, in adults, and for the treatment of progressive, well-differentiated, non-functional GI or lung origin neuroendocrine tumors in adults with unresectable, locally advanced or metastatic disease. Unfortunately, it's not indicated for the treatment of functional carcinoid tumors and for the treatment of advanced renal carcinoma or CC after sunitinib or sorafenib failure in adults, and used as adjunctive treatment of partial onset seizures associated with tuberous sclerosis complex TSC in adult and pediatric patients more than or equals to 2 years of age, and used for the treatment of renal angiomyolipoma associated with TSC not requiring immediate surgery in adults, and used for the treatment of subependymal giant cell astrocytoma (SIGA) associated with TSC in adults and pediatric patients more than or equals to 1 year of age, which requires therapeutic intervention but cannot be curatively resected. Off-label use, data from a randomized double-blind placebo-controlled phase 3 trial in patients with low-grade or intermediate-grade neuroendocrine tumors associated with carcinoid syndrome support the use of everolimus in combination with octreotide for this condition. And the data from multiple studies and the ISHLT guideline supports substitution of everolimus for mycophenolate in combination with reduced exposure calcineurin inhibitor (CNI) or complete CNI withdrawal post-transplant for prophylaxis of organ rejection in heart transplant recipient in combination with concomitant immunosuppression. Data from a small phase 2 study supports the use of everolimus in the management of previously treated Hodgkin lymphoma in patients who had relapsed or were refractory to prior therapy. Data from 3 prospective randomized controlled trials supports the use of everolimus starting at least 1 month post-transplant for prophylaxis of organ rejection in lung transplant recipients in combination with concurrent corticosteroids and reduced doses of cyclosporine. Data from a small phase 2 study supports the use of everolimus in the treatment of unresectable or metastatic thymoma and thymic carcinoma after failure of at least 1 prior line of platinum-based therapy. Data from a phase 2 trial in patients with relapsed or refractory Waldenström macroglobulinemia supports the use of everolimus for this condition. Mechanism of action: everolimus is a macrolide immunosuppressant and the mechanistic target of rapamycin, mTOR inhibitor, which has anti-proliferative and anti-angiogenic properties and reduces lipoma volume. In patients with angiomyolipoma, reduces protein synthesis and cell proliferation by binding to the FK binding protein 12, FKBP12, and intracellular protein to form a complex that inhibits activation of mTOR, mechanistic target of rapamycin. Serine threonine kinase activity also reduces angiogenesis by inhibiting vascular endothelial growth factor, VEGF, and hypoxia inducible factor, HIF1 expression. Angiomyolipomas may occur due to unregulated mTOR activity in TSC-associated renal angiomyolipoma. Everolimus reduces lipoma volume. 74% protein binding. Half-life elimination is 30 hours. Time to peak 1 to 2 hours. FDA approval date is March 30, 2009. US boxed warning: increased susceptibility to infection and possible development of malignancies such as lymphoma and skin cancer may result from immunosuppression. Only healthcare providers experienced in immunosuppressive therapy and management of transplant patients should prescribe everolimus. An increased risk of kidney arterial and venous thrombosis resulting in graft loss was reported, mostly within the first 30 days post-transplantation. Increased risk of nephrotoxicity can occur with the use of standard doses of cyclosporine in combination with everolimus. Increased mortality, often associated with serious infection within the first 3 months of post-transplantation, was observed in clinical trial of de novo heart transplant patients receiving immunosuppressive regimens with or without reduction therapy. Use in heart transplantation is not recommended.